This lecture is about the patellofemoral pain syndrome. So patellofemoral pain syndrome is a pain at the front of your knee, around your kneecap, that is a patella. It's a chronic condition that worsens with activities such as squatting, sitting, climbing stairs, and running. Also called as the runner's knees or the jumper's knees because it is more common when people participate in sports that involve running, jumping. Particularly females are more prone as compared to the males and the young adults. The pain and stiffness caused by the patellofemoral pain syndrome can make it difficult to climb the stairs, kneel down, and perform your basic ADS. Next is etiology, which is the cause for the patellofemoral pain syndrome. That it can be due to patellar trauma, overuse or the overload of a patellofemoral joint, anatomical or biomechanical abnormalities. There may be a muscular weakness, imbalance, or a dysfunction, and a use of improper sports training techniques or the equipment. That can be a training errors. Mostly, the patellofemoral pain syndrome is caused by the vigorous physical activities that put repetitive stress on the knee, like jogging, squatting, and climbing stairs. The problems in alignment may result in a kneecap, that is a patella, that shifts too far toward outside or the inside of a leg, that can be lateral or medial, or one that rises too high in the tracheal groove, that is a patella alta. Next cause may be the muscular imbalance or the biomechanical abnormality can cause patellar deviation and also provokes the patellofemoral pain syndrome. When VMO, that is the vastus mentalis obliquus, is not strong enough, the vastus lateralis, that is VL, can exert a high force and cause a lateral guide. That is a more common VMO. It's not strong enough, and that can lead to the lateral tracking of a patella. If there is a tight ITB, so it places excessive lateral force on the patella and can also externally rotate the tibia. Next is the weaknesses in the quadriceps can cause poor tracking of a kneecap within the groove. Weaknesses in the medial quadriceps allow the patella to track so far laterally. Another is a tight calf muscles. So it is a tight calf muscle which can lead to your foot pronation and increases the posterior force on the knee. So the foot pronation can lead to a compensatory internal rotation of the tibia or the femur that upsets your normal patellofemoral mechanics. Next is the clinical presentation. So how the patient with the patellofemoral pain syndrome will present. So the patient usually presents with a dull itching pain in front of the knee and is usually aggravated by activities that increases the patellofemoral compressive forces, such as the standing or the descending stairs, sitting with the knees bent for the prolonged time, and the kneeling and squatting. And squatting is usually also used for the diagnosis. You ask the patient to squat 30 degrees, so the patient complains of the pain on the interior of a knee, which is suggestive for the patellofemoral pain syndrome. In serious onset, an overload event like excessive stair climbing is typical. For the PFPS, pain when sitting with the flexed knee indicate tight quadricep muscle. Pain while sitting with the legs crossed indicate the tight ITB, like the tight gluteus maxima or the tight tensor fascia. Later, pain while walking down the hills lowers the PFJ, and pain while walking uphill indicates the tight calf muscles. So the pain when going downstairs shows the patellofemoral joint surfaces problems, and pain when going upstairs shows the impaired gluteus control. So pain only during activity, think of biomechanics, and a pain only after activities, think of inflammatory, or on the next day, go for the inflammatory. Pain on contractions, squatting, kneeling is suggestive for the patellofemoral pain syndrome. This was your subjective examination, like what you look for. And next is your objective examination. So observe the patella, femoral position, and muscle bulk. Observe for the alignment of the lower leg and the position of the kneecap, the patella, hypermobility of a tibiofemoral and the patellofemoral joint. There will be a lack of extension with the patient with the PFPS. So check for the range of motion, excessive use of a VL because VMO, there is a problem with the VMO. So there will be excessive use of the vasta lateralis, which will lead to the lateral tracking of the patella. VMO ability to fight, gait, or the runnings. Observe for the presence of an early heel rise level of the femoral and a pelvic control, and tightness of a heel cord and a flexibility of the feet, and a stair assessment. Make patient walk up and lower, up and down the stairs. Next is the physical therapy management. So you go for manual therapy, step by step, open and closed chest exercises, and then you go for the squatting here, quadriceps training. In the quadriceps training, you start with simple exercises like SLR, like isometric exercises. You go for the proximal strengthening. In this, you go for the hip strengthening, hip muscle strengthening. In quadriceps, you strengthen for the VMO. Modalities, electrotherapy is used for the VMO, and in some cases, for the orthotics.